Hi, my name is Jamie Riddell. I'm a neonatal nurse practitioner with Seattle Children's Hospital, and I've been working here at Providence since 1996. I started as a LPN and just worked my way up through the ranks. So I've done everything from LPN to RN to nurse practitioner. I understand that education really helps us do a better job, and so we really want to talk today about the late preterm policy. Approximately 10% of the births in the United States are preterm births. Of those 10%, 70% of those are late preterm infants. Those are infants greater than 34 weeks and up to 36 and 6/7 weeks. Preterm babies have a much higher morbidity and mortality than term babies do, and in terms of late preterm infants, their morbidity rate is about 6 to 7 times higher than a term infant. So we need to monitor them more closely, have heightened surveillance, and plans in place to make sure that we're not missing anything, and also to make sure that we're giving them the care that they need in order to get them home safely and in a timely manner. In the past, we've admitted these babies to the NICU, and now we're going to try and leave them with their families. And our videos are going to discuss today how we can monitor those babies and the interventions we can provide to them to help keep them safe and healthy. One thing I really want to reiterate is that these babies cannot just be treated as if they're normal term babies. So oftentimes they might be the same size of a term baby, they might appear to be a term baby, but the fact that they're 3 to 5 weeks early really puts them at higher risk for additional morbidities. Some of those morbidities involved are things like increased respiratory distress, hypoglycemia, hypothermia, significant weight loss or dehydration, and poor feeding. So we really want to just go over each of those ideas and talk about how we can prevent those issues from turning into significant problems that the baby has to be admitted to the NICU for. We also have an increased risk of readmission for these patients. These patients encompass about 70% of readmissions to the hospital in the first week of life. And so the best thing that we can do is good monitoring while they're in the hospital, good education for the families prior to discharge, and make sure that the surveillance once they're home is adequate so that those babies don't fall in the cracks and end up getting readmitted for being sick. So one of the best things you can do prior to delivery is establishing the gestational age and discussing that with the family, making sure that they understand that the baby's metabolic and physiologic immaturity can lead to complications once the baby's born. I think it's very helpful to start education prior to the baby being born so that the family is not surprised that they may need to supplement their baby, or that bathing may be delayed, or that breastfeeding support is available. Just having them understand all the things that are going to encompass care for their late preterm baby is really important. Education is 90% of the battle, and having them be able to care for their babies once it's born, prepare for their baby to go home, and then also making sure that they're prepared to monitor their baby once home and get a hold of the doctor if something does go wrong. Okay, one of the first things you need to do is move the baby into skin to skin as soon as possible. This will help stabilize the baby temperature, respiratory rate, heart rate, and just keep the baby warm from the beginning. Of course, provide NRP as the guidelines recommend, but continue to keep the baby in skin to skin unless necessary. It will be really important for these babies to be assessed by the NICU team prior to them being dismissed from the room. I know in some cases we allow the NICU team to leave the room and to be dismissed once the baby is born because the baby's on mom's chest and it's crying. But in these cases, it's really important for that baby to be assessed. The most common issue surrounding delivery and resuscitation is just the inability to open up those little air sacs and get good ventilation started. And so having someone assess how the baby's doing right after it's born is really important. Making sure that a warm blanket is added to the back of the baby, making sure the baby has a hat on very quickly, and then just staying in skin to skin until you have established that that baby is relatively stable. You're going to establish their gestational age and whether they're SGA, AGA, or LGA. And the weighing of the baby can be delayed for up to an hour, 2 hours of age. You want to try and make sure that the baby breastfeeds before you take the baby away from the mother and actually do the weight, length, OFC, give them medicines, all that kind of stuff. You want to make sure the baby's stable before you do all those things. I would never recommend weighing a baby who's having trouble maintaining stability anyway. If the baby's already cold, if the baby's tachypnic, if the baby just looks like he's dusky, you don't want to take that baby away and put them on the scale. If necessary, of course, if the baby looks like it's having some respiratory distress, you do want to get a pulse oximetry reading and, of course, call back either the NICU team with an RRT or call the LIP for additional evaluation. One of the next topics we're going to talk about is hypothermia, and this one is, I would say, one of the most common complications of the late preterm infant. Late preterm infants, although they may be the size of a term baby, don't often have the adipose tissue just because they are preterm. So adipose tissue provides them with the insulative layer to help them stay warm. It also is the brown fat that they burn. If they're not taking in enough oral feedings, they break down their brown fat and use that as glucose supply for their bodies. In order to stay warm, the baby needs a constant supply of glucose, and so oftentimes hypoglycemia and hypothermia go hand in hand. Some of the ways to best prevent the baby from becoming hypothermic, as we discussed previously, is keeping the baby in skin to skin as much as possible. When the baby's not in skin to skin, it's important to have a double blanket layer. Really teach those families how to wrap the baby up. As we all know, sometimes we go into a room and there's been lots of family members and the baby's just kind of unwrapped and essentially open to the elements. So just making sure that families understand it's really important to keep that baby swaddled nice and tightly, and to keep a hat on the baby anytime it's not in skin to skin. Babies also cannot generate heat as well as term babies can because of that adipose tissue layer. So some ways to decrease heat loss and maintain normal temperatures in the baby are to maintain a neutral thermal environment. That might mean that the temperature in the room is turned up a little bit if it's in the winter. Make sure that the baby's not near a window or the vents. Make sure the baby is kept swaddled. Some other things that you can make sure that you're doing is partial baths as opposed to full baths. Make sure that if you might even delay the bath for a long period of time, you might only wash the hair to start with. Just making sure that the baby is stable before you give it a bath. Again, I would never give a baby a bath who's already struggling. So if you're having trouble maintaining temperatures, if you have lower glucose levels, if the baby's a little tachypnic, or the baby has had any kind of complications, we would want to delay that bath for a period of time. You can also make sure that when you're weighing the baby after they've had their first breastfeeding, that you're using warmed blankets on the scale, that it's a very short and quick weight. Put the baby back in skin to skin as much as possible, and utilize the skin to skin as much as you can to stabilize those temperatures, especially in the first 24 hours of life. You're really going to have the most trouble with hypothermia in the first 6 to 8 hours, but in general the first 24 hours is really important to make sure that you've established normal temperatures and that their sugars are staying up, because those two are so interchanged. The other thing to be aware of is that a cold mom is going to make a cold baby. So if you're having trouble maintaining temperatures in the baby and it's been in a skin to skin, get a temperature on the mom. Maybe she's not the warmest person. And you might need to add some additional warm blankets or help warm her up before baby goes into skin to skin. The risk of hypoglycemia in the late preterm infant is 3 times greater than that in the term baby. This is for multiple reasons. The first being that their metabolic state is heightened because of their prematurity. Also, that their adipose tissue layer is not as thick as a term baby, simply because they are preterm and don't have that last couple of weeks of gestation to put on some fat. If a baby is not able to take adequate oral intake, either by breast or by bottle or whatever it might be, supplementing, so the baby doesn't have as much brown fat as they would normally have, given that they are preterm. Once they start to break down their brown fat in order to utilize glucose, they quickly use up what is available. The other thing that is very important to know is that once the baby is born, the glucose that is originally supplied from the mother is no longer available, and the preterm baby has a more difficult time adjusting to that cutoff of glucose. So as we talked about with hypothermia, hypoglycemia and hypothermia are very closely related because of that brown fat issue. And a baby who's cold is going to become hypoglycemic. A baby who's hypoglycemic will most likely become cold. So those two things are really important to keep linked in your mind. If you do have a baby who's cold, make sure you get a glucose, and vice versa. Any instability, including tachypnea, hypothermia, a difficult delivery, fetal distress prior to delivery, an APGAR less than 7, maternal magnesium, obesity, gestational diabetes, maternal hypertension, all of those things add on to the possible risk for hypoglycemia in the late preterm infant, and they are heightened because the baby is preterm. There are some things we can do to help prevent the baby from becoming hypoglycemic, and we will talk about those a little bit with the feedings. But in general, we want to try and stabilize the baby as much as possible and maintain a neutral environment to help them stabilize. Since late preterm babies oftentimes have trouble breastfeeding and even bottle feeding, it's really important to be very mindful of their glucoses early on. So get those babies into skin to skin right away, breastfeed within the first hour, and make sure that you're teaching the mom along the way, educating as much as you can on assessing the suck, swallow, breathe, and the ability to transfer milk. As we all know, preterm babies don't have the energy oftentimes or the stamina to maintain adequate feedings, so getting them onto the breast as soon as they're showing any cueing signs that they're ready to eat is really important. Vigilant monitoring for hypoglycemia is very important. Being aware of the risk factors prior to delivery will help you be prepared for and educate the family for what might come after. Making sure that you are aware of the risk factors and discussing those with the family can be very helpful to help them understand why the baby might need supplementation and why you're concerned. Getting the baby in skin to skin and breastfeeding soon after delivery within the first hour is very important. We talked about watching for their cues and just making sure that they are you're picking up on their cues that might be more subtle than a term baby would be. The first couple minutes that they cue might be the only time that they have to actually go to breast. Because of their stamina is short, they may only have 3 to 5 minutes to breastfeed for the first time. The other thing to be aware of is that it's really important to keep that baby in skin to skin when available, when possible. Having at least 10 to 12 breastfeedings per day. That sounds like a lot, but breastfeeding even in clusters or every couple of hours is really important. These are not babies who can go 6 hours or 5 hours without feeding. You want to make sure that they're fed at least every 3 hours, and most often we'll have to wake them up to feed and to look for those cues because they're going to be more sleepy than your term baby and just having more trouble stabilizing and becoming comfortable as newborns. Early education in the family can really help you when it comes time to actually intervene for the baby if the blood sugars are low. Please monitor the glucoses as policy states and intervene as necessary. Another thing that's really helpful is lactation support, and we have a lot of great RNs who have lots of experience with lactation support, but please get lactation consults when necessary. These late preterm babies have a lot of little nuances that will help them improve their oral feeding skills, and the lactation support person can really help you to teach the family how to pick up on the cues that may be more subtle than what you're used to. And then very importantly is to educate the family about signs and symptoms of hypoglycemia and when to alert the RN that they're concerned. If those things are including jitteriness, extreme lethargy, unable to wake the baby for feedings, or being really cold, or if they're noticing that the baby seems to have some dusky spells. All those things are really important to educate the family about so they know what to watch for and know when to call you. Respiratory morbidities are also increased in the preterm infant. These can include transient tachypnea of the newborn, respiratory distress syndrome, or respiratory failure and apnea. It's very important to realize that preterm baby lung development occurs past 34 to 36 weeks, and although we usually consider 34 weeks for lung maturity, in general, the alveolar sacs and the terminal alveoli in the preterm lung continue to develop after the 36-week mark. We usually think of 34 weeks as that big surfactant surge in preterm babies, but there are babies who that is delayed in, and if born at 35 weeks, they may have missed that surfactant surge. So the babies are at increased risk for respiratory issues. as well as increased risk for needing respiratory interventions at delivery. It's very important to make sure that the correct staff are present and that NRP is followed, and that we just make sure that we've established a stable respiratory effort and rate prior to leaving the baby with their family. The first couple of hours are very important and most important in monitoring the baby's respiratory status. In most cases, if a baby's going to have trouble respiratory-wise, it's going to be in the first 2 hours of life. A baby who is borderline saturated, saturating in the 85 to 90 range, would still appear pink, but might have more trouble with transition to extrauterine life and might be at higher risk for persistent pulmonary hypertension, which is essentially just fetal circulation that has not transitioned. Those babies can get very sick, and some of the highest risk for PPHN is in the late preterm infant. So as we discussed, ensure that the NICU team assesses the baby prior to being dismissed after delivery. Again, early intervention goes a long way to prevent long-term complications or readmission within a couple of hours of delivery. So just let the NICU team assess that baby before they're dismissed. The other things that are really important to do are to get the baby into skin as much as possible and soon after delivery. This will help stabilize their respiratory status, will help stabilize their oxygenation and their heart rate. If you have any concern about their vital signs, that maybe they're tachypnic, maybe they don't appear very pink, maybe they're mottled, any of those issues, or if they're grunting, flaring, make sure you get a pulse oximetry reading. That gives you a lot of information about how the baby's doing. Be mindful that if the baby does have some degree of PPHN or just hasn't transitioned completely, the best place to put the pulse oximetry is on that right hand. You can take a pulse oximetry reading on other extremities, of course, but be aware that if the reading is low or the extremities are very cool, it's very important to go to that right hand. So when you get your pulse oximetry reading, if the baby is having any respiratory distress, making sure that you're talking with the licensed independent practitioner or the physician about what you're finding. A normal saturation range for a baby within the first couple of hours of life is really just greater than 90%. We would expect a baby to be 95 or greater going forward within a couple of hours of birth, but the transitional period, as long as they're satting greater than 90, is very acceptable. If you have a baby who's dipping down to the 88, 89 range, it actually probably does warrant you discussing that with the LIP, just because that probably takes warrants some more monitoring and maybe even down in the NICU. And that's increasingly true if there's some respiratory distress. So transition oftentimes looks like a baby who is a little tachypnic, might be flaring a little bit, might be having a little bit of retractions, but looks very comfortable breathing and is satting 90 or better. That's pretty normal for a couple of hours after birth. But if you have a baby who looks like they're uncomfortable or they're desaturated, 85, 84, less than 88%, they look like they're having trouble breathing, that is definitely something to talk with the LIP about or call a rapid response. Very important is adequate positioning. So as you can imagine, these preterm babies might have some issues with neck control. They might have, their heads are going to be larger than their body can support perhaps. They don't have a lot of upper chest and body wall support. So making sure that you're teaching the families to position those babies well, that they're not up on the family's chest with their head kinked under, making sure that airway's nice and open. When they are in their crib or in skin to skin, that they're well positioned, making sure that airway's open. And that goes for going home as well, teaching them good positioning, back to sleep, all those things, because late preterm infants are at higher risk for apnea, especially during a deep sleep cycle, as well as obstruction. Late preterm infants are at higher risk for SIDS, and so educating families on important good positioning, safe sleep practices, no use of tobacco, things like that are really important to start early on. Make sure we're modeling those in the hospital as well. One of the most common complications of a late preterm baby is feeding difficulties. So breastfeeding, of course, remains the number one best way to support a newborn baby, including late preterm babies. We do know, however, that they may have immature suck, swallow, and breathe coordination. They often don't have the stamina to maintain breastfeeding for long periods of time. They also don't have the muscle strength and oral motor coordination to be able to transfer milk from the breast. So in order to support mothers with breastfeeding, which we really take as high priority, we want to make sure that we're also supporting their milk supply. The baby may not be able to transfer milk, and so having the baby breastfeed first and then having the mom learn how to hand express or getting her to start pumping in the early couple of hours after delivery is really important. Establishing that milk supply in support with her, with the baby, will help that baby be successful long term. So although maybe the baby went to breast for 5 minutes or maybe even 10 minutes, have the mom or teach the mom how to hand express and then also get her set up with a pump so that if she is expressing any milk, we can give that to the baby also. In almost all cases, late preterm babies will require some degree of a supplement or support for lactation, and that might simply mean that the mom is hand expressing and giving some supplemental breast milk. It might mean that the mom has to pump and finger feed or use SNS, a supplemental nursing system, or that even formula is required, which is okay. We want to make sure we're supporting the baby and the family with whatever they choose. If the family chooses to not breastfeed and formula feed, we'll talk a little bit about how to safely bottle feed a preterm baby because they also have difficulties with bottle feeding as well. We do know that breastfeeding is a little bit more difficult than bottle feeding is, and that's simply because the baby first of all has to get the milk to flow, and second of all has to actually pull the milk from the breast, whereas the bottle, you can get the milk to just drip into their mouth, which we don't want either. So most of these babies will benefit from early supplementation, even of just expressed breast milk that's hand expressed. The other thing to know is that the number one cause for readmission in the late preterm infant is poor establishment of early breastfeeding. So making sure that we do establish that milk supply with that mother prior to going home. And that might mean hand expression, it might mean pumping, whatever that looks like for that family is really important to help prevent hyperbilirubinemia, hypoglycemia, failure to thrive, and dehydration with significant weight loss. It can be really helpful to review the risks prior to delivery with the family, things like being on magnesium, having a C-section, having breast augmentation surgery, a difficult breastfeeding in the past, not as able to establish a milk supply. All those things are really important to discuss prior to delivery so that you know how to best support her once the baby is born. Having her get the baby to breast within an hour of delivery is very important, and establishing either pumping or hand expressing within 6 hours after birth. That's been one of the biggest ways that we know of to increase milk supply early on, is early management of hand expression or pumping. The other things we can do to ensure that the baby gets a successful breastfeeding start is to make sure that they are getting that 10 to 12 breastfeedings a day. Discuss with the mother what you're seeing when the baby does breastfeed. Is the baby latched appropriately? Is the lip flanged out like it should be? Is the tongue down? Is she putting the baby to breast appropriately? Is she holding the baby there well? Making sure that you're talking about the cues of their late preterm baby, which may be very subtle, and making sure that the baby is swallowing and coordinating breathing while it sucks. Some babies will go to breast and just suck without having a breath and turn blue. Some babies have a really hard time getting to breast and will just cry hysterically. That's kind of a later sign of hunger. So making sure that the mom is aware of what those early signs of hunger are, because the late preterm baby is not going to be able to sustain cueing for long periods of time and will fall asleep at the breast. Again, we have really great lactation support here, and we've actually added some additional lactation support people, so it's really important to get those consults early on. There's a lot of things that lactation can help teach you and the family about how to help the baby best breastfeed, and that includes things like different positions, different monitoring of the cues, making sure that they are transferring milk. It might be adding a nipple shield. There's lots of things that the lactation specialist would be able to offer you in support of that mother and the breastfeeding baby. Educate the family about what breastfeeding looks like. It might be cluster feeding for a couple of hours during the day and then sleeping for 2 or 3 hours, or it might be that they have to wake the baby every 3 hours to feed. Because babies who are late preterm don't have the stamina and endurance, oftentimes those subtle cues could be missed and the baby might just want to sleep through feedings. That's not going to be okay for a late preterm baby who doesn't have the brown fat to burn to maintain glucose stability without feedings. Encourage the family to ask for help with breastfeeding and even formula feeding or bottle feeding. Because these babies, late preterm babies, have feeding nuances, it's really important to have the family make sure they understand how to best support the baby because they're going home with that baby in 2 days. So making sure that they know they can ask for help if they need it. You can always get an occupational therapy consult if needed, and of course you'd be speaking with the LIP about this. But if the baby, especially is bottle feeding, and the baby's choking or spilling milk out the sides, just not feeding well, it's really important to get those consults to figure out how to best support that baby. The other thing you're going to be doing is weighing the baby daily, like we do with all the term babies. A weight loss of more than 3% in a day, or weight loss of more than 7%, is pretty indicative of a poor feeding trajectory. We would hate to send a baby home who's lost 7% of their birth weight at 48 hours and have them come back in 4 days with severe dehydration. You can help the mom know what to look for in terms of dehydration. Have her put her clean finger in the baby's mouth and have her suck on her finger. Moist mucous membranes are very reassuring for a hydrated baby. We of course always have them watch the voids and the amount of urine output. And then the color of the urine is really important too, to make sure that the family understands if you're having brick crystals in your urine, the baby's definitely dehydrated. One really helpful way to assess active and successful breastfeeding is to assess that baby's breastfeeding or lactation twice a day, at least twice a day. Talk to the mom about what you're seeing, how the baby is latching, how the baby is positioned, whether the baby seems to be transferring milk or swallowing. But that will help her also when she gets home, because she'll know what to watch for. Making sure that they're breastfeeding frequently enough, or if they're simply bottle feeding, making sure that they are feeling successful in bottle feeding and able to wake the baby for cues. A baby who is having difficulty breastfeeding or difficulty feeding should have early intervention, and we have, I would like you to refer to the Providence, the new feeding supplement guideline, which we'll talk about. There's going to be a link, we'll talk about that a little bit in the future. Of course, we would like people to use express breast milk first if able, but if the mom doesn't have any express breast milk and the baby needs supplementation, formula is the next best choice. There can be a hydrologized formula if the parents really feel that strongly, and also there is a higher calorie formula if the baby is less than 2,500 grams. We do like to use a higher calorie formula. So speak with the LIP about what kind of formula you'd like them to supplement with. Ensure the parents understand the feeding plan and understand why it's necessary, so that they do go home and continue to follow that plan until they see their provider. It's really difficult to sometimes talk a family into using supplement if they don't want to, even expressing their milk if they don't want to. But I think the important thing to remember is that these babies, up until just a few weeks ago, were admitted to the NICU automatically and would often stay days at a time. So this is really a goal toward getting them home while still supporting their needs. Have the family understand the consequences of poor feeding, to include dehydration, hyperbilirubinemia, and readmission for poor weight gain. I think education is key, and if a family understands why it's so important, and they can see that it's working, it's really helpful to help them continue on the way home. Okay. And in general, I'm going to kind of place her sideline because I want to be able to have her pull the milk when she wants it, as opposed to the milk just dripping in her mouth. We're using a Dr. Brown, which is a slower flow nipple. And I'm going to just try and get her to alert to the nipple. Making sure her mouth is nice and open before I don't want to pry the bottle in, but when she tastes the breast milk, she may kind of start to open her mouth. And the other thing to be aware of is we don't want to force feed babies. So if she doesn't actually start cueing and taking the bottle on her own, you can do a couple of different things. Either give them a couple more minutes, like 15 minutes, and then try again. Or it might be a sign that the baby just really isn't ready to be feeding on their own. And I might need to wake her up a little bit more again. So this is actually a cue that she maybe doesn't want to be eating right now, but there's her mouth. Now if I can see, I don't know if you can see this, I'm going to fill the nipple about halfway. And I want her side lying with just her head propped up a little bit. She's starting to suck. And I want her to do 3 or 4 sucks and then take a break. And she's not doing that on her own, so I'm going to tip the bottle down. And I'm just tipping it down so the milk is not in the nipple, which should make her stop, and she's breathing now. And when she starts to suck again, I can tip the milk back into the nipple. And the nipple's only about half full, so it won't be drowning her. And I can hear her breathing and swallowing. So the suck, swallow, breathe is one of the things that they're very uncoordinated with. And so I'm just going to monitor her. And she's starting to spill milk out of her mouth, so I'm going to tip her up a minute. Spilling milk out of their mouth is a sign that the milk is coming too quickly, and so they're getting rid of it as opposed to swallowing it. So she's taking a break, just breathing, which is great. Their clusters of sucking will be about 3 to 5 sucks, and then some pausing to breathe. She's pausing, so I'm going to tip the bottle down. She's actually doing a great job. Even though she wasn't wholly alert and ready to eat, it appeared, she is still able to feed. And so this is one of the things that it's really important to know, is that their cues are much more subtle than a term baby. And I'm just going to see if she's ready again. And she's starting to suck, so I'm going to let her have milk again. 3 or 4 sucks. And just really letting the baby tell you when they're ready to eat again. So the pauses may be anywhere from a couple of seconds to even up to a minute. The longer, the more stimulation they have during a feeding, like my talking, the lights, any noises that are occurring, is actually more stimulation than they should have during a feeding. In general, I want the lights low, and I would not be talking in general. She's doing a great job pacing. I'm going to tip it down, let her catch her breath. And actually, she's taken about half this bottle, so I'm going to try and burp her now. Man, she's almost taken all of that. That's a good job, honey. So another good, in order to burp the baby, I'm going to burp her in my hand instead of putting her on my shoulder, because I won't be able to see her face and make sure that her neck is in good alignment and her airway open. So I'm going to take the palm of my hand and place on either cheek, my fingers on either cheek, with her chin in the crook of my hand. And then I'm going to lean her forward into my hand so I have really good control over the baby. Make sure she's not sitting upright, because the minute she starts to arch backwards, she could fall out of my hands. So I'm going to lean her into my hand and then just burp her. And I'm not squeezing tightly on her neck. I have a hold of her chin and her cheekbones right under her ears. I'm going to see if she wants to eat some more. So she started with 20 mils, a little more than half an ounce. And that's how much food she needs to take actually she's taking more food than she would have to for the first day of life. We'll have an attachment to the feeding supplement plan. So for the first day of life, it's 30 mils per kilo, and this baby weighs, let's just say she weighs 2 kilos. So you would multiply 2 kilos times 30 mils per kilo per day and divide that over the 8 feedings, and you'd have your volume that she would need, which would be about 6 mils for every feeding for the first day. So she's back to pacing herself. The bottle nipple's half full, and she's pausing now. And you can see again I have her in side lying position as opposed to laying flat on her back so that she can better control the milk flow. You can see her lips are nice and flanged out around the nipple. They're not tucked under. And she's not spilling any milk, which tells me that she's controlling the flow herself. She's getting down to the bottom here. So I shouldn't be hearing any noises if she's, if she starts to make some noises, like choking for sure, but if she starts to make some noises like stridor with each suck, if she's making this noise, that tells me that she's working really hard to protect her airway, and you want to make sure that the flow of milk slows down. They should not be having stridor sounds when they're eating. Sometimes that just means the baby's tiring with feedings and it's time to be done with the feeding, and sometimes it just means that the flow is too fast. And that's just me burping her. Would you mind hitting silence there on the bottom? Yeah, thank you. The nice thing about this way of burping is I can see her face, I can see that she's still pink, I can see that she's breathing, I know that her airway's nice and open, and she kind of seems like she's done eating. You can see how her mouth is just hanging open. She's definitely not cueing to feed, and she looks like she's passed out. I'm going to check again just by laying her down. Sometimes babies will kind of rally again after they burp, so we'll still try and burp her, but she looks pretty tired. I think that's probably it. The hat's bigger than her head. Her bow. So then if I was her mom or dad, once I was done feeding her, after I got a burp out of her, I would put her into skin to skin with good positioning and then let her just kind of fall asleep. That helps us with two things. First of all, it helps with reflux, if there's any. Kind of helps them start to digest their food, and also helps them stay warm and just kind of stabilize after they've done this big job of feeding, which it is for them. You can see she's pretty done. She's clenching her eyes, and her mouth's just kind of slack. So I would say at this point she's done eating. So I'm just going to work on getting a burp out of her and then swaddle her tightly and put her back in her bed. Thank you. Babies are very likely to have hyperbilirubinemia. Jaundice is much more common in the late preterm baby, and it's heightened by the fact that the hepatic and bilirubin conjugation pathway is immature, just like the baby is. Can also add on to that poor feeding or dehydration and weight loss, and you have a recipe for readmission for jaundice. So making sure that those babies are screened early on and knowing what the risk factors are, including the maternal risk factors, baby risk factors, and any previous children or siblings who had issues with jaundice. If you have a mother who's had 2 other kids who all required phototherapy, it's pretty likely that this one will also. So having early intervention for those things is really important too. Oftentimes it's helpful to follow up those jaundice levels early on, 18 to 24 hours, and if it's looking like that baby is already becoming jaundiced on that hourly Billy nomogram, the Butani nomogram, you can intervene sooner than you would had the baby been an outpatient. For example, if the jaundice level where you would start phototherapy is 10 and the baby's Billy is 8, you might start phototherapy early. Up in the mom's room, you're able to monitor her feedings, monitor the jaundice, and really help get that jaundice level down and still have them go home in time. So those are all things that we would consider for a late preterm baby that you wouldn't necessarily do for a term baby, expecting that they would be able to conjugate their bilirubin more maturely. Another risk of the preterm baby related to jaundice is their immaturity of their blood-brain barrier, which also has a decreased free albumin, which attaches to bilirubin. With all those risk factors combined with poor feeding and dehydration makes the risk of severe jaundice or kernicterus much more possible, which is why we have a heightened level of monitoring and need for surveillance for these babies. Making sure we know what their jaundice level is and what their rate of rise is very important. So you can expect to see requests for a jaundice level within 18 to 24 hours, and then a follow-up jaundice level before the baby goes home, or even within 12 to 24 hours. This will help us determine rate of rise. If you have a baby whose rate of rise is more than 0.2 milligrams per deciliter per hour, you probably would want to start phototherapy. If you have a baby whose jaundice level is anywhere near the phototherapy level while still in the hospital, that baby's going to be staying for phototherapy. This will just prevent them from having to go home, become even more dehydrated, heightened risk for severe jaundice or kernicterus, and come back much more sick. Education is key, so preparing the family for follow-up after discharge within 24 to 48 hours, depending on what that jaundice level is. They can go to their pediatrician, they can go to the postpartum follow-up clinic, but really need to be seen within 24 to 48 hours. So having them be aware of that early on will help them to have time to make an appointment and make sure that they're not getting missed or slipped through the system. The other thing that's really important is to educate them as to the signs and symptoms of worsening jaundice or kernicterus. While I don't necessarily recommend we scare everyone with the idea of kernicterus, it is really important that people understand what the risks are and knowing the signs and symptoms that the baby is getting sicker or has a higher level of jaundice. And while you review jaundice with your families every day, to reiterate what those signs and symptoms are of worsening or significant jaundice, a baby who just really isn't waking up for feedings repeatedly in a row, one feeding is okay, but 2 or 3 in a row, if they're just really not able to wake or stay awake for feedings, is concerning. Obviously, looking at the whites of the eyes, if the whites of the eyes are starting to be yellow, that's more concerning. The gums will actually start to turn yellow, and then you can show them how to blanch the skin and look for jaundice as well. A baby with severe jaundice goes from being really sleepy to being very irritable, difficult to console, maybe arching, or has a really high-pitched cry and doesn't stop crying. Those are reasons to get to your doctor right away. Late preterm infants are much more likely to have comorbidities related to their prematurity. So it's important to start teaching the families, even before birth and immediately following birth, what's expected for discharge. We want to make sure these babies have been monitored for an extended period of time and the surveillance has been adequate. And so these babies will be staying for 48 hours or longer as needed. It's really important to make sure the family is aware of that they're not going to be going home in 24 hours or 18 hours because they've had 4 other kids. It's not so much about making sure that they can take care of their baby, which is important, but it's also about making sure that that baby is going to be able to sustain normal behaviors like feedings, staying warm, and normal sugars. Education should start right away, as we discussed, making sure that they have a pediatrician picked out early on, understanding when to expect to go home, and what's expected before they can go home. So having an established feeding plan that's going well for at least 24 hours. We want to make sure that that baby's able to sustain feedings, whether it be by breast, whether it be with a supplemental nursing system, whether it be finger feedings or even bottle feedings. Just making sure that they're able to sustain. It's not uncommon for a 35-weeker to come out of the gate great, be able to feed for 12 to 14 hours, have no problems, and then as we're expecting increasing volumes, that baby is unable to take those feedings. So supplementing in the first 24 hours we expect about 30 per kilo of supplement if the baby's not breastfeeding well. The second day is about 60 per kilo and up as the baby gets older. So as we're expecting the baby to take more volume, oftentimes they are unable to sustain that. And we usually can tell that within about 48 hours if they're unable to sustain adequate feedings. Making sure the baby's voiding and stooling appropriately, making sure their vital signs are stable for at least 24 hours before they can go home, and finishing all those normal monitoring and surveillance that we do, including a CARC test. One thing I like to tell parents of late preterm babies is that the baby's head control, neck control, core strength is not as good as a term baby is. So you wouldn't want to leave that baby in a car seat for long periods of time. Although our car seat test is 90 minutes, that would be the extreme of what we would want a family to do. If they're going to be taking a long trip, take a break after an hour, lay the baby flat on the ground, kind of recuperate, feed, whatever they need to do to give that baby a break. That also goes to say, don't put them in swings until they're a little bit older. The little reclined bouncy seats are okay, but making sure that they're not living in those things for long periods of time. If they are using those devices, make sure that their positioning is appropriate, that their airway's nice and open, and that they're not cutting off their air supply when they're reclined. Some of the other things you want to talk to your families about throughout the hospital stay and before discharge are things like preterm feeding cues or preterm stress cues. And although you may not have had a lot of education regarding the preterm stress cues, they are things that you might think are kind of cute. Sometimes hiccups, for example, is a stress cue in a preterm baby. Not being able to stay awake and just falling asleep immediately when they're engaged. Eye aversion is another stress cue. So if you're messing with a baby and they're really not looking at you, you're trying to feed them and they're constantly looking away or immediately falling asleep, that's actually a stress cue that they're having too much stimulation. The things you want to see are those feeding cues. You want to have an engaged visual, eye-to-eye contact. You want to have a baby who is maybe nibbling on their hands, or just those normal feeding cues that might be more subtle than a term baby but are still there. Having the family be aware that the baby does need to sleep for prolonged periods of time, so not having lots of visitors, not passing that preterm baby around a lot. The baby is at heightened risk for infection and viruses simply because their immune system is not as strong as a term baby is. Model good hand hygiene and discuss good hand hygiene as you go. Model good safe sleep positions and discuss what that looks like. And then have those discussions with those families who smoke both tobacco and marijuana, that there is a heightened risk for apnea in smoking homes in preterm babies, as well as a increased risk for SIDS, both with preterm babies and with smoking and marijuana. And finally, we really just want that baby to be able to show us that it's physiologically stable before discharge. So having normal vital signs for about 24 hours prior to discharge, meaning a heart rate of 100 to 160, a respiratory rate of less than 60, and then having normal temperatures and normal glucoses. Making sure that baby is voiding and stooling as expected, making sure that the feeding plan is documented and understood and reiterated by the family, that they understand what the feeding plan is when they go home. Having a pediatrician appointment set up, having access to resources such as social work, a pediatrician, and to lactation, really important. And then just making sure that they have all their questions answered, that they understand safe sleep practice, that they have something set up at home, they understand the smoking, including marijuana, tobacco, and vaping. All those things are contributing to a less healthy late preterm baby. So just making sure that they understand all those educational points. Another really important thing to have families understand is that this baby is preterm, so they really shouldn't have even been born for another 4 to 5 weeks. In saying that, it's really important for them to understand that a baby grows when it's sleeping. A baby gets healthy when it's sleeping. So clustering care is very important. Have the baby feed, not more than 30 minutes for a total feeding, and then have the baby allowed to go back to sleep. You can hold the baby, you can have them in skin to skin, but don't be having tons of people over at your house, passing the baby around, keeping the baby awake for prolonged periods of time, because that eventually will become a detriment for that baby. Very important prior to babies going home is the families to understand and be able to verbalize understanding related to jaundice, the feeding plan, watching for dehydration, and for weight loss, and just understanding what those things look like. Having them understand when to call the doctor and when to be concerned is very important. So in conclusion, I just wanted to go over some of the most common complications related to preterm babies, which include poor feeding, hypothermia, hypoglycemia, dehydration, severe jaundice, and weight loss with dehydration. If a lot of the problems can be prevented with just good surveillance and education, and really want to just try and keep these babies with their families and have them go home in a safe way. So thanks for joining us today, and we will have some links and review at the bottom. Thanks.